We'll start in the next 5 minutes. So can I please urge everyone to please get your seats. You have a few minutes to get your coffees and teas. Please, a gentle reminder to please switch your phones to silent mode, and we will start very shortly. Yeah, thank you so much. Whilst we're waiting, I'm just going to run through a few housekeeping rules. So if we can go to the next slide, please. Yeah, so as you can see, we have cameras at the back. So there is a live streaming link. If you have any colleagues who would like to join us virtually and ask some questions for some of the panel discussions we have, I hope everyone has access to the webinar link. There will be observers participating in the discussions. And because we have live streaming and this recording will also be available offline after today's session, we just urge everyone to please keep your phones to silent mode so you can have the best quality of the audio for the recording. On the next slide, we will also show, sorry, the previous one with the QR code. It's okay. Roberta, let's get it going. Yeah. So if you need any information on the agenda, we are going full sustainability route. So we have something called a link 3. You will have A, the agenda, B, I think there's some information as well. Yeah. And C, I think most importantly is we will aim to have the program end at 4:30, and there are some bars and restaurants recommendations included in the link 3 as well. Not put by me, but put by my team on ground. So hopefully you like those recommendations. And most importantly, we also have the link to the white paper that is done by the Alliance, which kind of culminated and set off this summit. Next, we do have the Wi-Fi here. So if you need the Wi-Fi and you've not have access to it, please take a picture of the Wi-Fi details. It's Marriott Bonvoy, and the password is Anthony with a capital A 2024. If you need it at any time, again, please let us know. We're just going to hold for a few minutes while everyone takes a picture of the Wi-Fi password. Okay, all good? Great. So this is the floor plan. You do have, just to orientate yourself, we will have the room here. Next door is the coffee area. You can grab coffee and tea anytime you like. We will also have lunch at level 3 later in the afternoon, but all coffee breaks will be on the same floor. The gents and the ladies are towards the back of the room. So if you go on the back door, you turn out, the gents and the ladies are just right there. Yeah. So I think what we will do is we'll start shortly in the next few minutes. So just give us 2 minutes and we'll start the program proper. Yeah. Thank you. I need to get Dr. Oprah in the room. Then I don't have.
So should I wait here?
Maybe you wait there. I'll come here. Yeah.
Okay, good.
So ladies and gentlemen, good morning and a very warm welcome to our esteemed guests, including our co-hosts from the Thai Department of Disease Control. And 1 second, this script is not very intuitive. And the Thai Ministry of Public Health and Welfare, as well as our guests who has flown in from afar, as such as the US, Western Europe, the Middle East, and across the Asia Pacific. We also have about 50 people who is slated to join us online, so we're very happy to have such a great turnout today. My name is Candice, and of course I will be comparing for you today. Today's summit is monumental. It brings together like-minded individuals like yourselves across the hepatitis care continuum, from civil officers to community centers, to ignite a regional discussion on advocacy and policy shaping initiatives much needed to achieve a hepatitis response across Asia, to achieve a hep-free Asia. But before we do that, I just want to maybe bring forward Roberta, who has put all of these efforts together. She's the director who leads the APAC Liver Disease Alliance. So without further ado, Dr. Roberta Sano, please.
Thank you, Candice, for the welcome, and thanks all of you. So, welcome everyone to the APAC Liver Disease Alliance Summit. This is the first in-person summit that the APAC Liver Disease Alliance organizes. I'm really excited, proud, grateful to see so many individuals committing to eliminate hepatitis in APAC here in this room. So thank you very much for joining us today. Before we start, I would like to, first of all, thank the Department of Disease Control from the MOPH Thailand for co-hosting the event with us. I would also like to thank Abbott and Roche for supporting this event, and our strategic partners at the Alliance, the Harvard Medical School, the Hepatitis Fund, the Yellow Warriors Philippines, the International Liver Cancer Movement, the Global Liver Institute, and the Coalition for Global Hepatitis Elimination. I would also like to thank our knowledge partners, Vista Health, and the team from APCO for all their support and for organizing this event. So today's program is the result of months of behind-the-scenes work with our co-host, with our speakers, moderators, partners, and experts in our network. We built and designed this program in order to meet one objective, which is facilitating knowledge and best practices sharing in order to help policy improvement for better hepatitis elimination and to reach the hepatitis elimination target as per the WHO recommendation by 2030. So we have a mix of keynote lectures and panel discussions. The first part of the day is really dedicated to a number of individual presentations. So we will hear from the Ministry of Public Health of Thailand. We will hear from one of our board of directors from the Hepatitis Fund. Our knowledge partner, Vista Health, will tell us why eliminating hepatitis is not only a health priority, but it's also economically and socially viable. We will then learn more about the progress that 3 countries are making when it comes to eliminating hepatitis: Thailand, Taiwan, and Pakistan. After that, we'll move into the second part of today's agenda. And here we'll have 3 panel discussions. The way we have thought about these panel discussions is really to address with our experts their thoughts, their ideas, their recommendations about, number 1, designing an effective national action plan for hepatitis elimination. Number 2, translating this plan into the reality, how to implement a national action plan. And then the third panel will bring us our attention to the patient. How can we optimize the patient journey and making sure that every single step from prevention to diagnosis and treatment is well addressed. And we'll then conclude with some closing remarks. And I know there is a lot of text here, but we will conclude with some closing remarks where we want to look at the future and then learning from today's insights and knowledge shared, what can we do collectively? So before I let you delve into the content with our experts, let me just share a few data. So in APAC, more than 174 million are currently infected with hepatitis B or C virus. Hepatitis deaths have reached more than 820,000 per year, which means that every hour almost 100 people die because of hepatitis in the APAC region alone. This represents 63% of the global death rates. And in addition, hepatitis is also the leading cause of other liver diseases, including hepatocellular carcinoma, which is the most common liver cancer and also the second deadliest in the Asia Pacific. A lot of progress has been made from a number of countries across the region, but also there is still a lot that can be done in order for us to meet that target of eliminating hepatitis by 2030. You will see that one of the themes for today's program is multi-stakeholder and multilateral collaboration. And this is not only the theme of today's program, it's also one of the key pillars that the APAC Liver Disease Alliance drives. So at the Alliance, we believe that every stakeholder has something to gain and something to offer, from ministries of health, policymakers, funders, international organizations, academia, clinicians, patients, caregivers. Everyone in the hepatitis ecosystem has something to gain and something to offer from collaborating. So in the spirit of this collaboration, I really encourage all of you to use today as an opportunity to share your knowledge, to ask questions, and why not to explore opportunities for further collaboration in our region. At the Alliance, we are committed to act now. So that's why we have provided today this neutral space for all the stakeholders to come together and collaborate and share. The objective is really to facilitate policy discussions, to share knowledge, to share best practices with one mission in mind, which is reducing the growing burden of liver disease across the APAC region and its social and economic impact. With that, I would like to wish you a very nice day. I look forward to learning from all of you today. And yeah, I hope you will have a good time. Thank you very much again for being with us.
Thank you, Dr. Sano. And please give us a few minutes, but we would like to warmly welcome our guest of honor, Dr. Opat Kawimpong, Permanent Secretary, Ministry of Public Health, Thailand, who will share on Thailand's journey and commitment on hepatitis elimination, which has translated to the newly published hepatitis guidelines in Thailand. He's just a few seconds away, so we'll just give him a few minutes. Yeah, sorry, a few seconds. So can we please give a warm welcome to Dr. Opat, please? He's coming, I promise. Dr. Opat.
สวัสดีครับ Good morning, distinguished delegate, esteemed professor, colleagues, ladies and gentlemen. It is my great pleasure to speak to you about viral hepatitis, which is one of the most significant public health challenges. The key role played by partnership in eliminating viral hepatitis as a public health threat is highlighted in our gathering today. I will be reflecting on the importance of collaboration and the essential step we must take together to eliminate global viral hepatitis. Viral hepatitis is a silent killer that claims over 1 million lives annually, with more than 350 million people worldwide living with chronic hepatitis B or chronic hepatitis C. Many of them are unaware they are infected, leading to preventable death from liver disease and cancer. These numbers are rising, but the good news is that we have the tool for prevention, diagnosis, and treatment. What we need is contributed action to implement this solution globally and nationally. The World Health Organization goal to eliminate viral hepatitis by the year 2030 is ambitious but achievable. To meet this target, we must cut new infection by 95% for hepatitis B and 80% for hepatitis C, and prevent hepatitis-related death by 65%. Make sure that hepatitis B and hepatitis C are diagnosed at 90% and cases are treated 90%. The target requires strong political will, investment, and most importantly, partnerships across all sectors, both the government and private sector, healthcare providers, civil society, and community. Thailand has demonstrated what can be accomplished through effective partnerships. Our country has made significant progress in reducing viral hepatitis cases by integrating viral hepatitis management and medical service into our universal health coverage since 2023. Following a successful pilot project, we have expanded screening, ensure access to affordable treatment, and launched campaign to raise public awareness. Importantly, we have worked closely with community-based organizations to reach the most vulnerable, including people who inject drugs and marginalized population. However, the patients are pathway found that access to treatment and referral has restricted by previous requirements such as the qualification of meeting physical diagnosis protocols and treatment criteria. Thailand Ministry of Public Health has decentralized the screening process for hepatitis B and hepatitis C by reviewing protocol to enable different healthcare professionals to perform the screening. Moreover, physicians who have been trained to prescribe treatment for viral hepatitis infection can provide patient care supported by consultation system involving both general practitioner and gastroenterologists. Barriers such as lack of awareness and stigma are addressed by initiating educational campaigns in communities to raise concern about hepatitis B and C disease and the availability of screening. To reduce stigma, we can enhance health literacy by offering accurate information. The Ministry of Public Health has collaborated with many stakeholders to address the issue of viral hepatitis. A good example of this kind of collaboration is the Global Health Sector Strategy on Viral Hepatitis, developed by the World Health Organization, which provides a roadmap for member countries. By aligning our national effort with this global strategy, we can ensure that we are all moving in the same direction toward the shared goals of viral hepatitis elimination. Ladies and gentlemen, Thailand has been a commitment to eliminating hepatitis by establishing strong partnership at all levels. It is important to play your part in the fight, whether you are a government official, a healthcare provider, a community leader, or a patient advocate. Together, we can ensure that viral hepatitis prevention, diagnosis, and treatment are accessible to all, leaving no one behind. In closing, I would like to express my gratitude to all of you who have dedicated yourself to viral hepatitis elimination. We have made significant progress, but now is the time to step up our efforts. Let's stay focused on working together to eliminate viral hepatitis for all. It's time to take action now, and our collective effort can make it a success. I wish you productive meeting and enjoy your stay in a beautiful city of Bangkok. Thank you very much. ขอบคุณครับ
Thank you so much, Dr. Opat. Yes, go ahead. So, thank you so much. So, we would also like to invite Dr. Chiwanan to provide the next keynote address. Sorry, this is the Dr. Dr. Niti is not able to make it today, so Dr. Chiwanan Leipiriyasuwat, who is the Senior Advisor to Ministry of Public Health, will be giving the keynote remarks on behalf of Dr. Niti instead. So, Dr. Chiwanan, please.
Good morning, distinguished delegates, esteemed professor, colleagues, ladies and gentlemen. It is my honor to be here today to highlight the incredible partnerships that are driving us toward the elimination of viral hepatitis in Thailand. Hepatitis particularly viral hepatitis B and C, remains a global health challenge. But through our collective efforts here in Thailand, we are proving that elimination is not only possible but achievable. Our success is driven by the strength of the partnership we have built across sectors. As many of you know, viral hepatitis continues to affect millions of people worldwide, and Thailand is no exception. For too long, hepatitis has been a silent killer, leading to liver disease, cancer, and death, often without symptoms in the early stage. However, the government of Thailand has demonstrated strong leadership in this fight. In alignment with the World Health Organization target to eliminate hepatitis by 2030, Thailand has embraced a national strategy focused on prevention, early diagnosis, and access to treatment. No single entity can eliminate hepatitis alone. The key to our progress lies in the robust partnerships we have formed. This partnership have brought together government agencies, healthcare providers, civil society organizations, the private sector, and international partners. Each of these partners has played a unique and essential role in driving our hepatitis elimination effort forward. The Ministry of Public Health has taken on essential leadership, ensuring that the hepatitis prevention, screening, and treatment programs are embedded within Thailand's universal healthcare system. Our dedicated healthcare professionals from urban hospitals to rural primary care units have worked tirelessly to diagnose, treat, and care for individuals affected by hepatitis. Without their commitment, we would not be where we are today. Moreover, community-based organizations have been instrumental in reaching vulnerable populations, raising awareness, and reducing stigma around viral hepatitis. Their work has ensured that even the most marginalized communities have access to testing and treatment. Our partnership with international organizations such as the WHO and global health NGOs have provided viral support, ranging from technical expertise to financial assistance. These collaborations have strengthened our national response and positioned Thailand as a leader in viral hepatitis elimination effort in the region. The result of this partnership have been transformative. That is, firstly, Thailand's universal hepatitis B vaccination program for newborns since 1992 has been a game changer, reducing hepatitis B prevalence in people born after 1992 from 4.5% down to 0.6%. This remarkable achievement is a testament to the power of prevention. Secondly, through partnerships, we have scaled up screening efforts across the country. Early detection of viral hepatitis, particularly in high-risk population, is saving lives and preventing complications like hepatocellular carcinoma. This year, we're screening around more than 2 million people. Thirdly, direct-acting antiviral for hepatitis C, which offer a cure in over 95% of cases, have become widely available thanks to partnership between the government and the private sector. These treatments are now accessible and affordable for the majority of those who need them. Finally, joint efforts between the government, civil society, and media organizations have led to impactful public awareness campaigns that encourage testing, treatment, and vaccination. This campaign have also played a crucial role in reducing the stigma associated with hepatitis. While we celebrate our achievements, we must recognize that there is still more work to be done to fully eliminate hepatitis in Thailand by 2030. The path forward requires us to, the first, sustain investment in viral hepatitis program and ensure that screening, vaccination, and treatment remain accessible to everyone, especially in underserved regions. The second, continue innovation by investing in new technologies, diagnostics, and treatments to further improve our national response. The third, reach the most vulnerable by working closely with civil society organizations to ensure that high-risk and marginalized populations receive the care they need. Thailand's progress toward hepatitis elimination is a shining example of what can be accomplished when we come together with a shared vision. Through the power of partnerships, we have made significant strides in saving lives, improving health, and offering hope to those affected by hepatitis. Let us continue to strengthen these partnerships, knowing that together we can achieve hepatitis elimination in Thailand and inspire the world in this global fight. Thank you.
Thank you so much, Dr. Chiwanan. Thank you. And please invite you back to your seat, please. Thank you. And now, without further ado, we will have our keynote address by Benedetta Neta, who is the Deputy Director and Fundraising Manager for the Hepatitis Fund. Benedetta, please.
Yeah, thank you. Hello, everybody. Good morning. I'm humbled to be staying in front of you today at what feels like a pivotal moment for the Asia Pacific Liver Disease Alliance, this first summit. As Candace said, I'm the Deputy Director for the Hepatitis Fund, but I'm also a proud board member of the APAC Liver Disease Alliance. I'm very happy to see a group of people gathered and united in the dedication to tackle one of the Asia Pacific most urgent public health threats. Now, I was asked to come here and talk to you about investments and how this can deliver an impactful change to support hepatitis elimination. And Roberta has mentioned this before. We're all painfully aware of what the numbers for the Asia-Pacific regions are. WHO, with this recent report, has talked about this. What I'd like to point your direction towards today is the fact that this is not just a healthcare crisis. this is a looming economic crisis for a lot of families, for a lot of individuals. Let's just think of the fact that in Vietnam, as an example, the cost of a course of treatment for hepatitis C can be up to maybe 6 months of a person's income. This is not just something that we're gonna fix today, but it's something we need to keep in mind when we talk about hepatitis elimination. Now, you've heard it even before, you know, we have the tools, we have the medications, the vaccines. One thing we're missing, or two things we're missing that are very important, are the economical means to talk about elimination, but also the political will. And these two factors go hand in hand together most of the time. Without the strategic, well-directed investments, we are not going to generate enough evidence to shift that political will, to make those investments a long-term political change, policy change for the communities. And we do need this investment in prevention, in early detection, in accessing to treatment, if we want to scale up hepatitis programs. When I'm talking about well-directed and strategic investments, I can give you two examples. The Hepatitis Fund has funded in 2019 a first round of grants, two of which were in Vietnam and Pakistan. These are two very different countries, and the projects were very different in nature and scope. One in Vietnam, implemented by a big organization, international implementing partner, PATH, and the other one in Pakistan by grassroots organization. I'm sure, unless you're Pakistani, you won't know about them, the ASD Foundation. Two different projects that had one good thing in common. They had a partnership between the funding agency, in this case, the Hepatitis Fund, the implementing actors, so the civil societies, but most importantly, the local government. Without this partnership, you're not going to be able to generate the impact, the catalytic impact that you want. And in the case of Vietnam, the local authorities very quickly saw that this is actually convenient for them and that they'd rather reimburse the cost of a PCR for hepatitis C rather than wait for that person to get really sick. And in Pakistan, similarly, the government has taken over the cost of PCRs, which meant that our investment could broaden its scope geographically. So this is to say that, yes, we do require collaborative effort, coordinated effort, but treating patients is this is not just about treating patients, which obviously is our focus, but it's also about making sure that we reduce the long-term economic burden for the country. And of course, as we are all painfully aware, the APAC countries, especially in lower income APAC countries, the investment landscape is very fragmented, is very underfunded, under-prioritized. But there is one evidence that we all should be keeping in mind. Investing in hepatitis elimination today is reducing the cost long-term. This has been proven by many, many studies, and we all play a critical role in advocating and driving action towards prioritization of hepatitis programs. And I'm talking to you as experts, as representative of academia, of healthcare companies, funding agencies, governments. We all play a part in this bigger mechanism towards hepatitis elimination, and it's up to all of us to play our part together. Now, there are systemic barriers, definitely. For those of you who don't know, I used to raise funds for particle physics, and I thought that was very difficult. I thought that was something people really didn't connect. I didn't know how easy I had it before I came to hepatitis, to raising funds for hepatitis. It's very difficult. I've been looking for that guy with a big pot of money that could come and save us. I haven't found it yet, so if you do have their number, please give it to me. But I do believe there is a way to overcome this barrier. We need to combine philanthropic funding together with private investments. And this is the key to scale up to produce that evidence that I was talking about earlier. We could do this in a variety of ways. The hepatitis fund model, meaning the partnership between governments, healthcare companies, NGOs, and funding agency is working. It's one way to do it. We could go through blending finance models, reducing the risk for one investor so that we can unlock potential of a bigger pool of funding. There are if you'll talk to Roche today, they'll tell you all about the innovative financing mechanism, the social impact bonds, which work very well if we ensure that we define clear, measurable health impacts. You find your way. The clear thing is that hepatitis has no boundaries because hepatitis is an infectious disease that knows no border. So the reply we need to have is cross-border, needs to be multi-stakeholders, needs to be coordinated. Let's face it, it's difficult for governments to fund hepatitis. Many low and income countries don't have enough funding for healthcare, let alone for funding, resourcing a hepatitis program. So it is up to all of us to bring the attention towards the prioritization of hepatitis programs. We as a community, as the APAC Liver Disease Alliance, but I'm talking about each one of us, need to be able to provide the countries that need it with the resources, the expertise, the best know-how to really make the difference and scale up and spark the investments into viral hepatitis program. And I believe that the APAC Liver Disease Alliance is perfectly placed to do this, to drive this agenda as a neutral platform. But I cannot stress this enough. It is up to each one of us. As I said, I haven't found the person that is coming to fix it for us. We don't have that person. We might farm them and we might create them, but it's not among us at this point. So we need to do it ourselves. And yes, we've talked, the time is now, hepatitis is a silent epidemic. All of this is true, but we've been saying this for a long time. So what does it take for us to really act and commit ourselves today for the millions of people whose lives depend on it? Thank you very much.
Hello, everyone. So we've come to a momentous moment of photo-taking session, and Dr. Niti has arrived. I'm going to orchestrate human traffic movement, so please bear with me. If I draw your attention to the back of the room, we have a lovely backdrop, and we will also have a symbolic signing ceremony of the fact that we have so many like-minded individuals here gathered to work towards eliminating hepatitis as a public health threat by 2030 in the region. So firstly, as we get the hotel staff to move the pledge, I would like to invite, of course, Roberta, who leads the Alliance, to join us at the back. We will also have Dr. Niti and Dr. Chiwanan to join us at the back. We will also have one representative for each of the partner organizations. So we will have Dr. Benedetta from the Hepatitis Fund. We will have Bethany. We'll have Yihui as well. And of course, we will have our esteemed speakers today. So we have Dr. Tran and Dr. Nguyen to please join us at the back. We also have Dr. Jasmine. We have Dr. Asif. We also have Will, who will join us at the back, please. So can I just get everyone to please gather at the back while we move the pledge pedestal in front of you. And we'll also have maybe one executive from Roche and Abbott to join us as well at the back, if that's okay. Yeah. Ladies and gentlemen, please. Yeah. And of course, we will have Chris and Dee to join us at the back as well as partners of the Alliance for the Pledge. Thank you. Sorry, please give us 1 minute because Dr. Niti is taking the lift up. But all of you are much more efficient than I thought. That's why we are here waiting for a few minutes. Yeah, I was like, I'm going to move 15 people. We're going to need 5 minutes. But no, everyone's very, very fast and efficient, so which is great. Yeah. Okay, so maybe I can get everyone to please be positioned in front of the backdrop for the photo. So when Dr. Niti arrives, he can just be in the center. Yeah. So please, can I please get everyone to stand at your favorite spot for your photos? Make sure you have your favorite angle, left, right, face. Not sure what's your favorite angle. So some people like to stand at the back like me. Some people like to stand at the corner. So can we just get everyone gathered together for a photo? And Dr. Niti will just stand in the middle. Dr. Jasmine, anywhere you prefer. We'll have a few rows because some people like Will is exceptionally tall. And Chris, I need to manufacture my height. Do we have Diana, everyone here? Okay, great. Okay. So sample photo first, everyone. 1, 2, 3, cheese. Okay. Which one? Okay, official photographer in the middle here, always. This is the Ministry of Public Health photo. So most important one that will go on socials. Yeah. Okay. Everybody look at the center camera. 1, 2, 3. One more? Okay, great. Just give us a few minutes. We just need to wait for Dr. Niti to arrive. Is he, I think...
He will take another 10 minutes.
10 minutes?
Yeah.
Okay. Then... yeah, okay, yeah.
Let's sign now.
Yeah, okay.
Then we go for
Yeah, okay. Yeah, so unfortunately, when we built the pedestal, I imagine it to be much smaller and lighter, but it is quite hefty because we want it to be significant to our commitment and demonstrate how much we care about this. So we will have, it's a very symbolic thing that everyone will sign together and then we can take a picture of that. Yeah, so the team will pass you some markers. So it'd be great if everyone can, just sign. It's almost like a guest book, Yeah, so if we can do that, the team will pass the markers for the pledge signing. Yeah, just give us 1 minute. But thank you so much. Can I also maybe invite, while we're doing the signing, I just want one photo with Roche and Abbott and Ministry of Public Health. So without their support, we would not be able to host this event. So can I invite everyone else to please gather here at the pledge pedestal, and then I will have Ministry of Dr. Chiwanan and Dr. Chatri in the middle, with our representatives from Roche and Abbott for a quick photo, please. So can everyone else, everyone else who's not from Roche, Abbott, or Ministry of Public Health to please stand here for the pedestal, in front of the pedestal. Yeah. I just want to arrange a quick photo. Yeah. Okay, everyone ready? Okay, one more photo. Roche, Abbott, and Ministry of Public Health. Yeah. Okay, so official photographer, please. Roche, Abbott, Ministry of Public Health. Yeah. Yeah. Okay. Sorry. Roberta, do you need to be in the... Yes. Sorry, what? Sorry, give me 1 minute. I have 3 people talking to me at the same time. Just 1 minute. I have 2, yes.
Yeah, can we like open like this?
Oh, okay. Can we have everyone more in the center, please? Yeah, just in the center. Yeah. Okay, ready? Okay, thank you, everyone. Okay. Signing, you know, like those close-up shots. Thank you so much, everyone. So we will commence with the pledge signing. Dr. Niti, unfortunately, is still another 5 minutes away. So after the pledge signing, we will have a coffee break. Yeah, thank you. Yeah, so we will have Roberta to do the first signature, and my team will take a photo. Yeah. Dr. Chiwanan, and Dr. Chatri, can we please invite you to also join us for this symbolic moment, please? Can I get yeah. Dr. Asif and Dr. Abru, can I invite you to join us as well? Please, thank you. Thank you so much, Dr. Chiwanan. Thank you, Dr. Asif. Yeah. Invite him later. He's talking to Kunfeng. Dr. Jasmine, are you here? Would you like to join us too? Yeah. And Jade, of course. Mihail, you'll have to sign too, right? Yeah. Oh, sorry. Chris and Diana, will you be signing the pledge as well? Will you be signing? Yeah, it's over there. Thank you. Dr. Chen and Dr. Nguyen, can I invite you to sign the pledge as well? Yeah. Dr. Pisit, would you like to? Yeah. Up to you, but it's participate. Yes, of course. Yeah. It's okay. Please join us for the pledge signing as well. Sorry, it's a queue because I'm, yeah. Hello, everyone. So we will thank you for signing. We have everyone accounted for. So we will have a short coffee break. We'll just get everyone to come back around 10:10. So the free flow coffee and tea, as you already know, is next door. You know where the ladies and gents are. We'll see everyone back online at 10:10. Hello, everyone. We will start very shortly. So we're just trying to get everyone back into the room. So everyone who's joining us online, thank you so much for your patience. When we get coffee, it will always take a bit more time. So we'll start very shortly. Okay, welcome back everyone. And next we will have the presentation which is on the white paper that the Alliance members have put together, and we will have on the topic, the quiet crisis, why addressing the urgent need for viral hepatitis elimination is socially and economically viable in APAC by Will Brown, who's the Senior Director of Vista Health Singapore. So Will, please. Can we have a round of applause for Will? Thank you so much, everyone.
Long way up. Great. Welcome back, everyone. Thank you very much for having me. Pleasure and an honor to be here today. I'll be presenting, thank you, as Candice mentioned, on what we call the quiet crisis of hepatitis, and reporting back from the white paper, which was published last year, and still findings very much relevant today. I hope you're all suitably caffeinated. It's a good slot to have after the coffee break, as opposed to after lunch when everyone will be asleep, I'm sure. So let me get started. So I'm going to talk today about why hepatitis elimination is viable in APAC, and also to start with, touch on the clinical and the economic burden, and how we need to tackle it collectively. So let's start with some of the statistics. Now, you've seen some of these before. Thanks for stealing them, Roberta, and also Benedetta. But no matter how often I see these statistics, they still shock me. So I do want to reiterate them today. Deaths in the APAC region from hepatitis top 1 million per year. That's 2/3 of the global burden, so massively over-indexed in Asia. And on top of that, 200 million, approximately, people are living with hepatitis B or C. And a staggering 90% of those remain undiagnosed. So huge, huge proportion, not even knowing that they are suffering from such a disease. Now, we can also look at the economic burden from two angles as well. The first is on the individual. In countries where there is not reimbursement or there is not coverage for treatments, and this is treatment alone before we talk about consultation, diagnostics, anything else, can be 3 to 6 months of an individual's income just to be treated for hepatitis. And on the macro scale, if we look at this, the overall impact to economies, in Australia alone, we can account for 26 billion Australian dollars to hepatitis-related productivity impacts. This is huge. Not only that, to tackle this, to address this burden, you are also preventing HCC. So tackling this is not only tackling the statistics that we see here in front of us, but also we're going to have further knock-on effects into HCC as well. So very, very critical. That's why we're all here today, to see how do we address this. Now, last year, as I mentioned, we worked with Roberta and the Alliance and many of you in the room actually as experts on the seminal white paper for the Liver Disease Alliance. Now, this stemmed from literature reviews, desk research, expert engagement and input, and the findings painted a very clear picture. The need is stark, as we've just seen, but if we can galvanize a response, there is a path to elimination, and that's the key finding. Now, bit of backdrop. Global policy on hepatitis has been enforced from the WHO, from the UN Strategic Development Goals since at least 2016. However, if we look at where we're at today, in Asia Pacific, most territories are not currently on track to meet the goal of elimination by 2030. So I guess the message from this is we are behind. How do we catch up? From our findings, our assessment of many of the health systems and the responses to hepatitis, we found some good news as well. It's not all doom and gloom. We have seen some successes in many countries, territories across the region. We note Australia, Japan, and Taiwan as examples in the paper. And from the learnings from those systems, we identify 4 key success factors. So the first is the presence of a national plan. The second is sufficient political will and coordination. The third is adequate funding in order to actually implement the plan. And the fourth is well-established and integrated screening programs. And critically for this, or for all of the factors, in fact, is how do we tailor this to the diverse populations, not just across the region, but within each of the countries in the region as well. The success stories also tell us that not only is elimination achievable, but it's also highly economically beneficial. Every case study that we looked at across the region, whether a small-scale pilot within certain countries or regions, through to national level activities, show very, very convincing economic data. Every single case study shows a return of in excess of 50% return on top of paying back the original investment. So not only are those efforts having a big clinical and health impact on individuals saving lives, but also at an economy level, making returns on the investment that is being made. And this is really critical because it tells us that if action is taken, not only is there health benefits, but countries' economies are also going to benefit, flourish as a result of this. So in the paper, how do we achieve this was the question of the recommendations section. And there were 5 policy recommendations. Now, you'll see here that there are mentions of HCC, liver cancer as well. And this is because, as I said at the beginning, it needs to be an integrated approach that is taken. So the 5 recommendations from the paper, which are applicable across the region. First, more comprehensive national action plans. Countries are starting to build these plans, but they need to go further. Second is to expand screening and treatment and integrate that within existing healthcare systems. So making sure that the end-to-end of the patient journey and patient experience is cohesive and is seamless. The third, which Benedetta has spoken to, trying to find our mystery person with a big pot of gold or of cash. But securing greater funding is critical, of course, and is not an easy task to undertake. But through integration between hepatitis efforts as well as liver cancer efforts, there is the opportunity to secure greater funding for these efforts. And through that, we'll also ensure timely and affordable access to treatment. So bringing patients through that journey from screening to diagnosis through to treatment and long-term care. And the fifth, which is last but very much not least, is to increase public and political awareness. Now, we can do a lot of things top-down at the regional level, at the national level, but if in the grassroots people are not engaged, this will not take us as far as we need to go. So community efforts, policy champions, community champions are going to be needed to make sure that this is not just a top-down effort or a lot of talk, but actually translates into actions. So to conclude, I'm going to start at the beginning, where I said if we can galvanize stakeholders to respond, then there is a path to elimination. So we, with the APAC Liver Disease Alliance, call upon every stakeholder to work together to implement these recommendations and to make change. Every person and every group represented today can take steps now, tomorrow, to put this into action. It doesn't have to be big, whole national level change. There are small steps that we can all take in our day-to-day jobs. So let's not hope for elimination by 2030. Let's start now and make it a reality to save millions of lives. Thank you.
Thank you so much, Will. In our next 3 best practice sessions, you'll be hearing from 3 leaders, past and present, of national level hepatitis programs who manages or implements some of these national plans. To kick us off, I'd like to invite on stage Dr. Chatri Julapech, who is the head of hepatitis coordination sector at Thailand's Department of Disease Control, to share with us how Thailand transformed its hepatitis response to achieve national control. Dr. Chatri, please.
Good morning, everyone. Welcome to Bangkok and welcome to Thailand. Today, I want to share the practice to hepatitis B elimination. Thailand has a population of 66 million people. The average prevalence of hepatitis B is 3.4%. For individuals born before 1992, the prevalence is 4.5%. While for those born after 1992, it is 0.6%. Thailand has a program implementation. This is a timeline of program implementation in Thailand. Start in 1986, introduced the screening test for all blood units to detect hepatitis B. And in 1992, initiated vaccination for all newborn against hepatitis B. In 2016, we provide free and antenatal hepatitis B screening for all pregnant women. And in 2022, we asked TAF as a first line treatment for the chronic hepatitis B, and TDF is a first line treatment for pregnant women with chronic hepatitis B infection. In 2023, implement screening for viral hepatitis B in individuals who was born before 1992. And in this year, 2024, we have a revised and simplified guideline for hepatitis B guideline. This is diagnostic and treatment services for hepatitis B in Thailand. The campaign to promote hepatitis B screening begin in the community. And in PCU or primary care unit and sub-district health promoting hospital can test screening for hepatitis B by use the hepatitis B surface antigen test. And if patient test is positive for hepatitis B, they will be referred to a community hospital for further evaluation and treatment. Additionally, if patient meet the criteria to meet specialty such as GI, community hospital can refer to the regional hospital or provincial hospital to treatment of hepatitis B or C. For PMTCT, in Thailand, pregnant women can antenatal care in the PCU and sub-district hospital. And in PCU and sub-district hospital can physical examination and collect the blood for testing, such as CBC, DCAP, syphilis serology, anti-HIV, and HBs antigen. If test for hepatitis B positive, the patient referred to the community hospital for evaluation and treatment. And when the child was born to mother with hepatitis B, we have a pediatrician to care this group of child. In Thailand, over 1,000 public hospitals provide a free hepatitis treatment under the USC or Universal Health Coverage. Can treat at hospital or refer to other hospital. The cost of hepatitis B treatment in Thailand, yearly cost of TDF is about $106 per year, and cost of TAF is about $60. For the reimbursement from National Health Security Office, hepatitis B can reimbursement for screening about $1.5 per test. Additional treatment costs are covered within the fixed per capita payment in Thailand. This year, Thailand has released a new version of the hepatitis B guideline. This update includes a revised indication for treatment hepatitis B, especially extended criteria to patients over 35-year-old with normal ALT can be treated with this guideline. This slide shows the result of hepatitis B immunization in Thailand. The hepatitis B immunization in Thailand began in 1988, and by 1992, it was implemented in all provinces in Thailand. And in 2016, we have a prevalence survey. We found that the prevalence of hepatitis B in people who was born before EPI program had increased prevalence while we compare with people who was born after EBI program. And for seroprotective level of anti-hepatitis B, we found that people who were born before EPI have a lower seropositive level when compared with people who born after EPI program. This slide shows is screening for hepatitis B program for individual born before 1992. Since October 1923, we screen about more than 2 million people in Thailand. That we found percentage of hepatitis B surface antigen positive is 2.7%. Challenge in immunizing hepatitis in Thailand. The first is general practitioner trained in treating hepatitis about 60% of the total number of government hospitals. In Thailand, we have about 1,000 hospitals, government hospital in Thailand. The second is there is a lack of strategic data for some indication at the national level. Way to address the challenge, first is promote and accelerate training in hepatitis B and C treatment among general practitioners by use e-learning, and a doctor can access by this link and learn e-learning. When complete the course, he will receive a certificate. And second is develop the surveillance system, data, research, and innovation related to hepatitis B and C. We try to develop system to collect data from every hospital in Thailand. Thank you.
Thank you so much, Dr. Chatri. Next, I would like to welcome Dr. Jasmine Poo, who is the former director of the National Hepatitis C Program Office, Ministry of Health and Welfare from Taiwan, to share with us about Taiwan's end-to-end national hepatitis elimination strategy and program and progress in Taiwan. Dr. Jasmine, please.
Thank you. Thank you. Good morning, ladies and gentlemen. I am very honored and pleased to be able to join this event and share our experiences, especially when I was the former director of when I was the director of the NHCP office in ministry, starting December 2016 to January 2023. Today is I try to for this topic I can speak for days, but only got 15 minutes. I try to summarize them into 6 major aspects to share what I think why we are consider some we have already have some been successful in some aspects. So before I jump into that, I should give you some background of Taiwan's hepatitis and liver disease control. The government has been doing this over 50 years now. As an island, we were having hepatitis prevalent for some time. 50 something years ago, we started to try to control hepatitis A, and then we started a national vaccination for Hep B since 1984. So because of a lot of sad stories in the country here and there, we have many very dedicated, enthusiasm doctors, hepatologists who dedicated their life to trying to control the liver disease. So so when they have some when two of our experts went to the 2015 Glasgow meeting for the summit, World Hepatitis Summit in 2015, the experts group gathered together to have this commitment. So they say that to get set targets towards the elimination of hepatitis as a public health threat. So we have our Professor D.S. Chen and Professor Zhuang was there. They were there, and they were not just come back and do the regular things they normally do in the hospital and the university. Instead, they're trying very hard. They started to raise awareness. For example, this slide showed they started to using the media. They form a forum. This is a newspaper dated March 28th, 2016. And in the meantime, they go. I believe I wasn't there. I believe they talked to our minister, our government, many times to address these challenges. I mean, the hepatitis C challenges in Taiwan, and there could be some. There's an opportunity for us to tackle that in a relatively short time. So after this, and our government, our leaders think, well, yes, liver disease has been a threat to Taiwanese people, and now we have opportunity, not just only Hep B, because we have been doing the screening, the vaccination, the screening, and the treatment for years, and now we have opportunity to tackle Hep C too. So why don't we do that? I forgot to say, after all these years, our policy infrastructure has formed that our CDC, our Center for Disease Control, they're responsible for prevent hepatitis. And our HPA, Health Promotion Administration, they're responsible for the screening and the education. And our NHI, our National Health Insurance Administration, they're responsible for the treatment. So, government always like this, you're responsible for this, I'm responsible for that. So they are doing their jobs independently, sort of. So that's the context, the environment when the office was set in 2016. So I was mentioning our Professor D.S. Chen. They speak, and Professor C.J. Chen. He was a vice president. I mean, the government. They went together in the forum. They originally set 2013, aligned with the Glasgow commitment to this means zero liver diseases. It's a political announcement. But it starts with the political will and the public support. Sorry. Okay. And when I talk about political will, what reflects really mean on the three aspects, I think. Strong wills that they declare in many places that from many different government leaders, not just vice president, our minister, some city mayors and across different level of government, and also reflected on securing budgets. So we've been hearing a lot, raising enough funding is necessary. And they also reflected on the strong leadership, a clear roadmap in data management. And when our office trying to find some icons to do promote poster, and they come forward and they are free. So we want to collect we want to use our resources very effectively. They also a strong political will showcase. So. And I mentioned not just central government, but local health bureaus, because later on I will talk about Hep C in Taiwan, that we have geographic difference. So it's not the strategies cannot think of as a one size fits all. In the past, the local bureau tend to, or whatever you say from the central government, I would just follow. And but in Hep C elimination case, we want to tell them, you have this data. We support you with the data, and you should trying to identify your own problem and your own resources, and we support you to find your own strategies. So this is a photo shows when they talk about the prisoners' treatment, screening, or education, and the local bureau called up all these bodies, collaborators together. They have this collaborating meeting together. So this is also local health bureau take the lead, and they own these projects. So I think this is also very important. And good planning and implementation, our minister thinks we don't want to do that by 2013. We want to make it earlier, because it's a good thing. The people with hepatitis, they cannot wait that long. So he has the ambition to trying to do that as early as we can. If we have enough resource, if we do it earlier, we actually use less resources because it's infectious diseases. So that's what we thought at that moment. We spent over a year to develop a Taiwan hepatitis C policy guideline. In those guidelines, we reviewed all our data, our earlier research results, and all the current resources and infrastructures that we have. So with all this together, we have these policies that we focus on treatment first, because we have DAA, using treatment as a prevention measure. So when we talk about this part, we actually trying to make new drug accessible, new drug access, not just funding, but also the treatment guidance, the reimbursement, and it's an expensive drug. Not every hospital is interested, things like that. We want to we want that drug is being those drugs can be accessed everywhere in Taiwan, and that was not that easy in the beginning. And then we know half of our patients are not diagnosed yet by a research. So the second phase, we emphasize the screening effort should take place at the second phase. And then after all these efforts, when we really going to toward the end of the treatment screening efforts, and we need to focus on the treatment, the prevention part. So we sort of the turn upside down of the public health measures, make it reverse. And we also emphasize whatever we do is have these principles that precision make it more cost-effective and continual care, and make that means seamless services from prevention and to treatment. And localized care delivery, again, different places have different problems. So, for example, for the precision public health, we said we identify high prevalent areas, and we talk to the local local bureau, local health bureaus, and we have mountain and remote areas, and they we increase the access to the treatment and the screening services. And we have general areas that we develop screening strategies specific fit the low prevalence areas, and we also have a focus on special groups. We have developed targeted screening strategies for them. So in that policy guideline, we also mentioned the action items should be the followings. So this is just what we made that. For the government, it is a must that we show the possible outcomes so that we can convince the budget holders that we use this budget and we have good return. So that's how we use the model, our economic modeling to have some projected outcomes. And there's all the things we do in the past 6 years and that we have written on the paper. And we have data surveillance. In the beginning, we don't have the anti-HCV. Okay, I don't have time. So we have a lot of we don't have the national data, so we use proxy surrogate indexes, but somehow we have this the map. So the local government understand they are at the high risk population. They should pay more attention on the resource on this. And then after some years, we have the national anti-HCV thing. Okay, I don't have time, but we have the data to the targeted screening program according to our research results. We spend a lot of efforts trying to locate where are the relevant data set, and we link them together, trying to make a cascade data that we can follow where are our weak link, so we can improve on that. For example, this is the reporting rate. So if your city local bureau have this number, and you will say, oh, I should catch up with my colleagues. So this could help a lot. We encourage public-private partnership. They would do a lot of screening efforts for us, and one by one, I think we one step at a time, and you show the success in small steps, and they could encourage the efforts still continuously going up. So this is for the map. We going small area at a time, and this is for the remote village. We have this award and trying to encourage their efforts. They actually got 99% of screening and treatment. So it's a very good results, and also this is for a dialysis patient. They will not go to the hospital because they already been to clinics for 3 days in a week. So instead, they're going to the hospital for Hep C treatment. The Hep C services goes to the dialysis units. So one by one, the dialysis units complete their microelimination. So I'm sorry for taking so out of time, control the time. So quick summary is that I think in the first phase, we should acknowledge the importance of the elimination. And we use a lot of data and our research to understand the context in Taiwan and set a feasible goal and make commitments. Develop strategy accordingly. Real-world data helps a lot, and the government could do is responsive and responsible. So with that, I thank you so much. Thank you.
Thank you so much, Dr. Poo. Thank you. It's always amazing to hear the progress that I think the Ministry of Health and Welfare has made in Taiwan. So last but certainly not the least, we'd like to invite Dr. Muhammad Asif, Chief Health, Ministry of Planning, Development and Special Initiatives, Government of Pakistan, to share with us about Pakistan's executive ordered novel 3-year program to test and screen the entire nation for hepatitis in order to achieve elimination by 2030. Dr. Asif, if you please join us on stage.
So, this presentation that pertains to Pakistan's program for the elimination of hepatitis C infection. So, this is the sequence of my presentation, and I'll give you a context of our strategy for elimination of hepatitis C in Pakistan, and we see it as a public health emergency. And then subsequently, I'll give you the conceptual framework for this elimination and an overview of the program for the elimination of hepatitis C and certain aspects about the financing of this program. And two important aspects about the health system strengthening in order to effectively implement this strategy. And these two aspects include integrated supply chain management and program information systems that are a must condition for an effective deployment of the elimination strategy, and then the provincial contributions. So coming to the context of this HCV infection as a public health emergency in Pakistan, this graph on the right side of this slide that depicts the national HCV prevalence projected since the first prevalence survey in Pakistan, that was in 2008. And we can see at that time the prevalence was 4.9. And then this prevalence, as this slide depicts, this prevalence steadily it escalated, and gradually it moved, it progressed towards, and now in 2025 we projected with an average annual incidence rate of 3.28%. By 2025, this prevalence rate will be 8.16%. And if this situation continues, then by 2030 it will become 9.31%. With this highest prevalence of HCV in the Eastern Mediterranean region and globally after China, Pakistan has the second highest burden of HCV. And thus Pakistan, as you can see, faces this emergence of public health emergency. And while under the SDGs 3.3, we are committed to combat hepatitis by treating 90% of the patients by 2030, and actually this necessitated the development of this strategy. So this is the conceptual framework for the elimination of hepatitis C, and this program targets the population with the potential burden of hepatitis C infection. And we can see what are the various factors that are contributing towards the population with the potential burden of hepatitis C infection. These are the malpractices that root from the healthcare side, as well as these are certain community malpractices. Healthcare malpractices include irrational prescription and unsafe injections, unhygienic and unsafe surgeries, unsafe management and disposal of healthcare waste, and unsafe blood and blood products transfusions. And this is the major element that contributes towards the proliferation of this infection in our setting, and then the unsafe dialysis practices. And this burden, similarly from the community, as you can see, the community malpractices that contribute towards this burden, they include unsafe barber practices, unsafe nose and ear pricking and circumcisions, sharing of needles and syringes by the injectable drug users, and unsafe sex practices in the vulnerable population. So all these healthcare related as well as community care related practices, they contribute to population with the potential burden of hepatitis C infections. And our strategy deals with this segment of population, and the strategy is universal screening of all the target population, that is age 12 years and above, and their diagnostic testing, and if they test positive, their treatment with the relevant medications. So the treatment strategy primarily pertains to two groups. One group is for the age groups 12 to 17 years, where we administer sofosbuvir and ribavirin combination daily for 24 weeks, and upon completion, we conduct sustained viral response test for to ascertain the treatment effectiveness. And for all those who are age 18 years and above, we administer appropriate treatment regimes depending upon the APRI levels, that is the AST to platelet ratio index levels and other such parameters that we envisage. And upon completion, we also envisage to conduct the sustained viral response test to ascertain the treatment effectiveness. So in this way, these two segments of two groups will be treated if they turn out to be they are screened positive and they are diagnostically, they are PCR positive, they turn out to be PCR positive. But side by, we would not let the tap open to flourish this infection. That is the preventive aspect. And for this preventive aspect, a communication strategy to improve health literacy in healthcare and community awareness for disease prevention and control shall be deployed, and it will address all those factors that we have highlighted on about the various malpractices in healthcare as well as at the community. For the healthcare interventions to curb this infection and to prevent this infection from happening and to bring about a stop to new infections, the various interventions will be institutionalized for injection safety and national prescriptions and rational prescription and use. In particular, the safe blood and blood products transfusion, that is the main aspect in the context of Pakistan. And this is very important because unsafe collection and transfusion blood and blood products has been the major reason for the HCV surge over the years. As a response, a national safe blood transfusion program is in place. I'll not go into the details, but that program primarily addresses this preventive aspect to curb and to prevent the further spread of this infection, to ensure the availability of safe blood and blood products. Similarly, interventions about safe surgeries shall be institutionalized, and safe management and disposal of the healthcare waste. So these are the preventive interventions that will be addressed through a comprehensive communication strategy. Similarly, the community interventions like safe practices of barbers, nose and ear pricking in the context of Pakistan, and institutional circumcisions, because these are the procedures that give way to the infections, and promoting safe sex practices in high-risk populations. So this is the conceptual framework whereby, as you can see, we are going to target the population aged 12 years and above through universal screening, through their diagnostic confirmation through PCR, and to offer the treatment to all those who turn out to be PCR positive. And at the same time, this burden of the population of the hepatitis C infection will be tried to be prevented. On one hand, from offering treatment, identifying and offering treatment to prevent further spread, and at the same time institutionalizing the various preventive interventions through a comprehensive communication campaign and strategy, and the institutional interventions to prevent the further spread of the infection and occurrence of this infection. So two-way interventions are going to be deployed. So the overview of the program is that this program, the overall goal and aim of this program is to eliminate by 2030 this infection from all provinces and territories of Pakistan. And the main objective for the phase 1, that is for the 3 years, year 2024 to 2027, screening of 50% of the eligible population. And what is this eligible population? That is all the population aged 12 years and above. We will be testing all the screen positive population for HCV infection, and we will be treating all populations tested positive for the HCV infection. And the various complementary objectives of this phase 1 would be strengthening of the supply side, that is the health system strengthening, as I referred earlier, with focus on supply chain management and building human resources capacity for the effective deployment of these interventions. Similarly, demand side, there would be a complementary objective of this program by institutionalizing the communication strategy that I highlighted earlier. And overarching and strengthening information systems would be deployed, and an effective monitoring and evaluation of the program will be the main objective in order to ensure an effective implementation of the program. So the program components, as I mentioned earlier, there are 3 components. That's one is the universal screening. Second is the diagnostic testing of all those who are screened positive, and then to offer the treatment facilities to all those who are PCR positive, and institutionalizing the communication strategy, as I had referred earlier, in order to have a comprehensive parallel preventive aspects for this program. These are the program national targets, and primarily this program would be screening 82.547 million people, and out of these screened people will be having diagnostic confirmation, molecular diagnosis of HCV, that is the PCR testing in 3.8 million persons, and to offer treatment to 3.259 million people who turn out to be PCR positive. So this is the target population that we are going to address through this program. These are the estimations of the screening test and all such. Like we can see that in this slide, the projected population of Pakistan is 253.9 million. And of this projected population, the eligible population, that is a population aged 12 years and above, that makes 65% of this projected population, and this is 165 million. And during the ensuing 3 years, we will be targeting 50% of this eligible population, that is the 82.47 million persons. This population will be screened, and if we take on the HCV prevalence of 7.5%, which is the current prevalence rate of HCV in Pakistan, the population for PCR test that turns out to be 6.1 million persons, and out of this 60% we estimate would be PCR positive, that makes 3.8 million persons, and these out of these 3.8 million persons, 620,000 persons are already getting the treatment through the existing system, and this program would target 3.259 million persons for the treatment of this HCV infection. So these are the salient estimation of the screening, testing, and treatment for the elimination of HCV Pakistan. So for the target population for the 3 years, 2024 to 27, 82 million would be screened, and 3.8 million would be tested, and that would be tested positive out of 6.1 million, and 3.2 million would be offered the treatment of this HCV infection. So these are the cost estimates to deploy these interventions of this target population, and we can see the total envelope to provide this strategy and to implement this strategy for 50% of the eligible population is 68.254 billion. Of this, the cost of screening test is 7.5 billion. And the testing cost turns out to be 15.5 billion, and treatment cost is 43.0, and while all others are the remaining operational cost, that includes the cost of the health system strengthening interventions, including the deployment of the supply chain managements and the health information systems of HCV elimination in Pakistan. These are the details of the financial expenditures and shares. As you know, this program is out of the total portfolio. This is supported almost 50% by the national government as well as the provincial governments. And this slide depicts in detail about the various contributions in terms of the rapid diagnostic tests, the PCRs, the treatment cost, and the operational cost. And we can see 100% of the rapid diagnostic tests are being sponsored by the federal government, while 30% of the PCR cost is sponsored by the federal government, 70% by the provincial governments, while the two governments share equal contribution in terms of the treatment costs, and the operational cost is also shared in 50% cost sharing basis between the provincial governments as well as the national governments. So this is a short description of the integrated supply chain management systems, and we can see that there would be depending upon the patient needs, the program managers and policy makers, they would select and quantify the items. They will conduct pooled procurement or strategic procurements. And then there would be warehousing and distribution of the health commodities in districts, at the district level warehouses and workstations, and they take on the stock and the various. And similarly, there would be further, at the level of the screening sites and the health facilities, and at the level of the treatment centers, all such, that has been depicted in detail in this slide. And we can see that this integrated supply chain management system ensures the effective implementation of the program interventions, and all such support that also requires an integrated supply chain management system. Actually, it requires designing and implementing a cascade of training for the health workers, while logistic management information system would complement this management system for the effective deployment of the interventions of this program. So this slide depicts the HCV information system data flows and how it is displayed, and we can see that there are various sites, that's the screening sites, the lab sites, for the testing sites, for the treatments, as well as the and in the context of Pakistan, the screening sites would be established at the various static healthcare facilities that include rural health centers, the Tehsil headquarter hospitals, the district headquarter hospitals, and the various tertiary care hospitals. And similarly, lab facilities are also available for the testing facilities. And for the assessment and treatments, again, the existing system will be mobilized. The existing healthcare management systems, as mentioned on this slide, the various DHQs, THQs, rural health centers, and physicians at the private setting. So all this information, there would be flow of this information to a central data warehouse. And from here, in the form of dashboards, this information would be available at the district level, at the provincial level, at the national level, and through APIs, this information would be shared with other information systems that are currently in place in our settings, that is the district health information systems, logistics management information systems, and various other management information systems. And as I mentioned earlier, the various information from the static and mobile screening facilities, designated laboratories for testing, and designated physicians for the assessment and treatment, all such information would be assimilated at the central dashboard, and through the API. Various APIs, this information would be available to various other information systems. At the same time, this information would be available for analysis and for utility to the authorized stakeholders like the policymakers, the Bureau of Statistics, and others. This slide depicts the various sets of information that would be captured on the information system, and we can see at the screening site, at the testing site, at the physician's assessment and treatment site. These are the various sets of information that would be captured in the information system. I'll not go into the details due to paucity of time. And this program management, this information serves as the basis for an effective deployment of the interventions. Like, for example, I give you a reference, like at the screening side, the client's basic demographics, his unique identifier, the rapid diagnostic test results, and in case of these become screen positive, their clinical history, their examination findings, their referral details, and disposal in case of RDT negative persons. And similarly, if they turned out to be screen positive, their referrals for the diagnostic testing, all such information would be captured into this system. And that would be part of the data warehouse, and that would be assimilated and shared with various other and aligned with various other information systems. And similarly, in case of testing sites and the assessment and treatment sites. So there is comprehensive set of information that would be available. So what would be the provincial contribution? As you know, the primary responsibility for the implementation of this program is the provincial health departments, their respective hepatitis control programs. The national government is primarily going to support the provincial governments in terms of provision of the screening kits. That is, the 100% cost of the screening kits would be provided by the national government. Similarly, 30% of cost of the diagnostic kits and 50% of the cost of the treatment medications is sponsored by the national government, federal government. But all the implementation that rests with the provincial government, and these provinces contribute by program management and providing healthcare networks. They'll co-fund the project in terms of medicines, like as I said, 50% of the medicines. They'll provide human resources, entire their responsibility. They will implement the preventive programs. As I mentioned in my earlier slides, the parallel activities, deployment of the interventions that are a must condition to close the tap for further spread of this infection among the population. So all the implementation of all the preventive programs essential for arresting the incidence of hepatitis, as we have now, is 3.28%. These preventive interventions are primarily meant to arrest this incidence. So these would be provided by the, like I referred, injection safety, blood safety, patient safety, including infection control, healthcare waste management, community-based hepatitis preventive programs. All such interventions are the responsibility of the provincial governments. So in nutshell, we can see that there are interventions, parallel interventions at two levels. One are the curative interventions in the form of universal screening of the target population, aged 12 years and above. And for all those screened population that turns out to be screened positive, their diagnostic confirmation through PCR. And for all those who turn out to be PCR positive, provision of treatment to all those PCR positive. So this is the one side of the strategy. To all the eligible population, in the coming 3 years, we are targeting the 50% of the population, and in exact numbers terms, this 50% of the population turns out to be 82.4 million. And out of this 82.4 million, 6.1 million would be PCR tested, and it is expected 3.8 million would be tested PCR positive, and out of this 3.8 million PCR positive persons, 3.25 million persons would be offered treatment through this program free of cost. So this is the national program that will be implemented in collaboration between the national government and the provincial governments at the same time through a collaborative efforts as a national responsibility. And all this, and this makes a total envelope of 68.254 billion. So this is the one set of information, and on the other hand, the second set of intervention is to close the tap, to lower the incidence of hepatitis C infection from 3.28% to down, so that to prevent the further spread of the infections. These are the preventive interventions. Primarily, they address our community behaviors as well as the healthcare malpractices that are consistently contributing towards the pouring in of the infection in the community. So these two sets of interventions are going to be deployed in parallel with the curative interventions. So in this way, we envisage over the coming 3 years, from 2024 onwards till 2027, we are going to target the 50% of the population 12 years and above on universal basis. And we are going to test them and screen them, test them and provide them with the treatment, and at the same time providing the preventive facilities in order to, preventive interventions in order to prevent the further spread of infection. So this is the bi-pronged strategy, curative versus preventive, being deployed at the same time. So with this, I finish my presentation. Thank you. Thank you very much.
Thank you so much, Dr. Asif. Thank you. So we will take a very short 5 minutes break because we need to transform the room very quickly. So if you like to grab some more tea or coffee or run very quickly, just 5 minutes. We'll just need to transform the room very quickly. So can I just get everyone's cooperation to please vacate the room for your personal safety, because we're moving some large furniture around as we are transiting to the panel discussion. So please be back in the next 5 minutes, everyone. Thank you. Hello, everyone. I just need everyone to vacate the room for 5 minutes, just so we can move large furniture around. So can I please trouble all of you to vacate the room for 5 minutes as we turn the room around for the panel discussion, please? Thank you. Hello, everyone. Thank you so much for helping us. As you can see, we now have the panels all set up, and we will start with our first panel discussion themed Creating an Effective National Plan. So without further ado, can I please invite our esteemed panelists to join us on stage? Of course, coming back on stage or in front of the room, more accurately, would be Dr. Chatri Julapach, Department of Disease Control, Ministry of Public Health, Thailand. Dr. Chatri, please. We also have Dr. Tran Dai Kwang, who is the Department of Preventive Medicine, Ministry of Health. Dr. Tran, please. We have Ms. Jade Chakawa, who's the Senior Advisor for Programs and Partnerships, the Hepatitis Fund. Jade, please. And of course, last but not least, we have Dr. Roberta Sarno to rejoin us as the Director of APAC Liver Disease Alliance. So I'm going to change roles. I was the moderator and now I am the panelist. So, so welcome everyone. So I always look forward to the panel discussions. We covered a lot of ground today, talking about what the national hepatitis response looks like for the region. We also had some very enlightening speech, particularly on, we have representatives from the Ministry of Health from Thailand and Vietnam here, which I think is very heartening because it shows us the commitment and the willingness of everybody here. So without further ado, I want to start with the first question to all the panelists, maybe to start from my left. From my left, yes, onwards. Clearly, I don't drive. Yeah, so what are the 3 key components that should be included in a national action plan for hepatitis elimination? Dr. Chatri, please. So can I maybe trouble Dr. Tran to, yeah, thank you. Sorry, as the moderator, I'm not giving up my microphone.
I think 3 components for a national plan for hepatitis elimination. First is prevention and awareness. Public awareness campaign is important to elimination program in Thailand, and including vaccination program. Lung vaccination is again high risk group. In Thailand, we have a EPI program in infant and newborn, but we still try to extend to the high risk group, such as drug user or such as other comorbid with HIV and hepatitis C infection. But we try to expand the group of hepatitis B vaccine. Second is diagnostic and treatment access. Universal screening is a nationwide screening program for hepatitis B in Thailand. But to ensure the positive result linked to treatment, we try to build a system for referral. Who is a positive for hepatitis B and can refer to the community hospital or province hospital. And lastly is a surveillance and monitoring system. I heard from the other country we have a week on the data system to monitor. In Thailand, we build a system now to ensure that patients with positive can receive treatment and confirmation test in hepatitis C. And for hepatitis B is to ensure that people who diagnosed hepatitis B, chronic hepatitis B to receive viral load test and the drug to treatment. Yeah, I think this three components for nation plan.
Thank you so much, Dr. Chatri. Maybe I can invite Dr. Tran to add on as well for Vietnam.
Yes, let me introduce myself. My name is Dr. Chen from the General Department of Preventive Medicine. And also, I'm a focal point for National Hepatitis Program in Vietnam. And to answer the question from Candice, because the representative from Thailand, he mentioned already mentioned on the component for the technical component. So from my view, so I would like to mention there's some other component to support for national action plan. besides the technical component, so my point of view think that so I need to include in the comprehensive national action plan. The first thing we need to include the situation analysis and assessment needs. That's a baseline to make to let us to set the target for action plan and set the vision for action plan. And also that's a baseline to come up with some solution. It's for facility. And the second one, I think so. We in Vietnam, so now so in Vietnam Action Plan we not include, but I think it's very important. And I saw in presentation from Pakistan the health financing. It's a very complicated and difficult component when because we need to make the investment very detailed and so that's the way we can include in the national action plan in Vietnam. So we want to do that, but it's still difficult for us because it's a kind of the comprehensive program. It's a very different, it's integrated from many different programs like the vaccination, blood transfusion, can treatment, surveillance, and also other some other components like the drug administration, vaccine, and drug assessment. It's a lot of the issue. So it's a kind of challenges for us to have some the breakdown budget for total action plan. So but even so even now we don't have, but I think it's a very key component is we should include. The last one I thinking about the M&E monitoring and evaluation. So we have experience from SIV program. Is they make a very detailed indicator for each program and for each action for SIV program. So I think to make the hepatitis action plan can go smoothly, so we have to create the M&E indicator. Yep.
Thank you so much, Dr. Tran. Thank you. Yeah. In case all of you do not know, we will summarize this in a post-event summary report that will be available online. So, and the recording will be there. So don't worry. Yeah. So I think we've heard from the people who drive the national plans. I just want to turn the light to Jade as well. So Jade, from the Hepatitis Fund's perspective, what do you think are the three components that are essential?
I'm going to build on what Dr. Tran said. I would say I think there are three key components that need to be in any plan. One is prioritization, secondly is costing, and third is budgeting. It's not easy, as Dr. Tran said, but prioritizing the activities that are needed based on the expected results of the plan is a key part of the process of developing an action plan. And based on that, having a realistic assessment of what are the expected costs, what are the resources that we need to actually implement those activities. And based on that, what is the budget that's available to us? What financing do we already have domestically? What financing do we potentially need to mobilize either domestically or internationally? Only then can the plan be realistic. And it's a process and not just individual components. It's that process of looking at those components together in order to have something at the end that is implementable based on the resources that are available. And part of that process is consultation with different stakeholders for the prioritization. What are the needs? What are we seeing on the ground? What are we hearing from civil society? What are their priorities? What is academia telling us? And from the Hepatitis Fund, it's really critical for us to have that information of not only what's in the plan, but what is required to implement against it.
Thank you. And how about from the Alliance perspective, Roberta?
Yeah, thanks, Candice. So I think we already heard many, right, of the key components. Let me just summarize and maybe add one more. From the Alliance perspective, clearly three things, right, that should be included in a national action plan for hepatitis elimination. So number one, really prioritizing every step of the patient journey within the national action plan, from prevention to diagnosis and treatment, with particular attention to linkage to care, because the literature is telling us that even, failing to link 5% of patients who are diagnosed to treatment will lead us to miss the target of hepatitis elimination. So that's really critical. The second component that I would mention, and building on what Jade said, really making sure that we have a sustainable and adequate source of funding. These can come from the local government budget, it can come from international organizations or from the private sectors. And this is also something that we highlight in the paper. Some of the countries with low resources could also explore other ways to finance these programs. For example, kickstarting with catalytic funding and then having the government to step in. We have many examples of countries who managed to make progress by using these alternative methods for financing. The last piece that I want to also mention is awareness and education. And we heard from Dr. Jasmine earlier how important it was, right, to educate everyone in the population. So we need to make sure that proper campaigns are implemented for the general public, for people at risk, for healthcare professionals. We also heard from Dr. Charter earlier about the early e-learning opportunities are given now to the physician. So I think it's really important if we look again, and I'll conclude with that, examples from countries who are providing access and making diagnostics and treatment and vaccines available and affordable, but still people are actually not getting them. Why? Because they are not aware, because there is stigma, there is social pressure. So we need to remove all these barriers. Thanks. Yeah.
So I was thinking about it and I thought there are 3 A's, which is awareness, accessibility, and agility, right? Because there's just so many key populations we need to address. There are different geographical considerations within each I don't want to say country, but I'm going to say country for ease of reference, that we need to consider, and different individuals have different ways of assessing health information. So many considerations when you look at the national plan. It cannot be perfect, and we recognize that because of the work we do in hepatitis. But I think, Dr. Tran, you spoke about having so many considerations, but it shouldn't stop us from developing the national plan. So maybe to build on Jade's point on pragmaticality, what were your 3 key things you go, okay, we can't hinder this anymore, let's just start. So what are the 3 things that say, okay, we'll build this foundation and we'll build from there?
Yes, so for back to the Vietnam situation, so Vietnam is one of the few countries have a national action plan very soon. WHO issued a guideline on 2016 for Asia Pacific, but in Vietnam, so we issued the first version of National Action Plan in 2015. And currently, so we running the second round of the National Action Plan for a period of 2021 to 25. And we already have a plan to update from the third round for 2026 to 2030, and by end of, I think in end of November we will conduct the hepatitis program review in collaboration with WHO, and we start for develop for the third round of the National Action Plan. For in Vietnam perspective, so we understand that only health sector we cannot combating the hepatitis, and we need we understand that the other component is plays a very important role, like the first one, the leadership and governance. The second one is community and especially for vulnerable group. So for developing the national action plan, so we consider to set the target and come up with the solution to focus on the three target group. The first, leadership and governance. The second one is the health sector, health system, and both of the public health service and private health service, and the last group is a community. So based on the first one for leadership and governance, so it's also there are two levels. The first level is the governance central. So we try to advocate for develop the new law of the prevention. That includes the state budget we cover the own fee of the screening for happy in community. So that's a way now. So we in advocacy, and to approve us, we need the agreement from Ministry of Finance and from the central government, and especially for National Assembly. So it's a very important agency to decide the policy for screening testing. The second one in the municipal health level. As you know, that's in hepatitis. The characteristic of the hepatitis program is integrated from many programs. So we need somebody like the committee within the leadership of the municipal health to coordinate the own department under the Ministry of Health to implementing the activity. So that's the solution. So for first group, second one is the health sector, health system. We have a 4 level of the health system from the central level, regional level, provincial level, and local level, includes the district and community health station. So in public health service, so we have almost 20,000 unit in health system, only in public, and in additional rather more than 3,000 private health facility. So we have we need to coordinate a lot of the facility in health system, and the third subgroup I mentioned on the community and vulnerable group. So we need to make the empowering of that group to be the chain and to be to involve them to some technical activity like the integrated with the CBO or any community group to conduct the integrating with SIV program. So that's what we have. We consider to the 3 target group.
Thank you so much, Dr. Chen. I think it's great you outlined one key. Sorry, excuse me. You outline one key point. At the policy level and at the government level, if there is no political will, it's very hard to unlock that pathway to make sure you bring all the stakeholders into the room so that you get as comprehensive a plan later, which is a prelude to the next panel discussion. So I'm not going to expound too much on that. Yeah, but I think this is an excellent point. We will make it as one of the key bullet points of the report. But maybe I want to circle back to Dr. Chatri. I think Thailand has a lot of has gone into the next layer of addressing the national hepatitis plan, right? You have very specific roadmaps you've built for hepatitis A, B, C, and D, if I remember correctly. And I think we also mentioned that there is a new hepatitis plan that's being announced, if I believe, this week. So maybe can I invite you to share a little bit on your approach on the latest plan? What's new? What have you learned that you've integrated into the plan on the 3 tenets you spoke about, right? Which is prevention, screening, and treatment of the plan.
Thank you. Thailand has a national plan to eliminate hepatitis B and C, but don't have the D and A. An outline of the Ministry of Public Health approach first for prevention. We launched EPI program for newborns in 1992, and everything free in Thailand, free vaccination, and we catch up we have a catch up program for newborn. We missed a shot on COVID era. Yeah. For other group, high risk groups such as drug injection, now we don't have a vaccination program for this group, but we try to expand this program for hepatitis B vaccine in this group, but now not ready. And the other program is PMDCT, because in the past Thailand has a high prevalence of hepatitis B, more than 8 or 9%. But after we give only vaccination, we can decrease significantly decrease prevalence. This program for PMDCT is integrate hepatitis B screening and treatment to antenatal care. Every woman with pregnancy can test free for hepatitis B, and the treatment is free. And we provide the screening into the rural area. Use the mechanism of PCU or sub-district hospital. For the screening, we have a national screening campaign. We have a target about 42 million people in Thailand to screening for hepatitis B and C, and we integrate the screening into the routine into a routine healthcare, such as NCD clinic or antenatal clinic and HIV clinic, also TB too. And we use community-based screening to ensure that marginal population can access treatment. And for the treatment, the key point is the centralization for treatment. In the past, Thailand prescribed the drug for hepatitis B and C by the GI doctor, specialist for gastroenterology. But now, for hepatitis B and C, the GP can prescribe drug, and GP or other special doctor can use e-learning on the website and can get certificate for prescription for hepatitis B and C drug. Yeah. I think the important for prevention, screening, and treatment is decentralization, everything to the marginal or rural area. Thank you.
Thank you so much, Dr. Chatri. I think we've covered a lot of ground, so I might maybe turn back to Jade and Roberta, and I'm going to combine a few questions. So Jade, I think Dr. Chatri and Dr. Tran has covered a lot of ground on what the national plan looks like, but you spoke about sustainability of the system, and we spoke about the fact that, the panel is the best representation of why everyone needs to come together. So from the Hepatitis Fund's perspective, what have you observed and learned from the fund's lens that allows you to take evidence or evidence-based approach to work with partners to kind of implement a very sustainable plan for when it comes to national hepatitis response?
Thanks. I think, before I answer that question, I also just want to say thank you to you and to the Alliance for carving out 2 sessions to talk about national plans. It's not something that we talk about enough, and it's really a key part of sustainability and having evidence-based interventions. It's really at the heart of that. So I'm happy that we're spending the time to dissect it today. And I would say that, firstly, that they're a really important tool for dialogue and for engagement with funders like the Hepatitis Fund. that it opens the door to having conversations of how we can support the existing national plans to be sustainable. The evidence is there, the prioritization is there, so we can then think about how we can work together. As the Hepatitis Fund, we work with local organizations, international organizations, making catalytic investments to implement actions against the national plan. So one of the first things that we look at in any investment we make in any country that we're working with is, do we see the political will of the government? Do we see that viral hepatitis is something that's been prioritized? And one of the key signals of that we look for is having a robust national action plan. So it forms the foundation of the dialogue and engagement with funders, not only ourselves, also, for example, with the Global Fund.
Thank you so much, Jade. So I think what you talked about, to catalyze progress, I think is the keyword you mentioned. And I think what Dr. Chatri, Dr. Tran, and you have mentioned is it's very important, right? We need to have insights. We need to know what the plan is supposed to help and whom they're supposed to help, so that the plan has its practicality and has its impact. And this kind of links back to Roberta's point on person centricity. And I know at the WHO level and in the healthcare space, person centricity has become increasingly important, and it's much more pertinent in hepatitis responses because of the large amount of, or the varied amount of vulnerable populations we need to address. So Roberta, can you speak a little bit more about the importance of, person-centered care based on your observations at the APAC level? Why is it so important again to make sure that the public awareness responses and having the right champions are so important to ensure we have the right reach, right, across the Gen Pop, even with the varied populations?
Yeah, thanks for the question, Candice. If we have to focus on people, so you mentioned two things, right? One is public awareness, and how do we include the voice of the people with lived experience, and the second one is political commitment, political will, and making sure that we have ambassadors within the government to push, right, for better recognition. So first component, public awareness and people with lived experience, this is critical. It's important to integrate their voice and their contribution since the beginning. So I know in this panel we are focusing on the design of National Action Plan, but we will also see how the contribution of people with lived experience is important as we roll out the program, right? So awareness is one component. We need to ensure that everyone within the community, within the population, and also at the professional level is well equipped with the technical capabilities to roll out a plan. But it also means that as we implement the plan, we want to hear back from the people, right? To know and to be informed about how the program is going. And I think, Dr. Jasmine mentioned that the importance of real-world evidence and looking at data from the real world, right? So policymakers should really get informed about all this data, analyze them, and use them to eventually adjust their plans as they get implemented. So it's important to think about feedback mechanisms. So that's one part. And the second part is really going back to the political will. I want to bring an example, right? Because when we look at the National Action Plan and the progress the countries are making and why some of they're progressing more than others. So having a National Action Plan is necessary, but is not sufficient. It's not a guarantee of success. There are many other factors that are important. And political will is one of them. So we have the example of many countries. I'm thinking about Japan, I'm thinking about Taiwan. It's important to have someone within the government, one or more people, to really support the cause of eliminating hepatitis. Yeah, thanks.
Can I add to that?
Yes.
I really like the point that you make, that it's not just about having the plan, but it's what do you do with it? What is that comes next, and designing it for that action that we want to have. And one thing that I think we saw, I've got two examples from the Hepatitis Fund when we've seen that work really well, is firstly in 2021, 2022, we worked with the WHO. We funded a project where they developed and supported the development of national action plans. An example of that was in Bangladesh. And using the operational plan that they developed, Bangladesh was able to leverage increased domestic resources in their next funding round by taking that plan and using it to advocate for additional health budget for viral hepatitis. And secondly, that they were able to use that for discussions with the Global Fund for their next round of resource allocation. So it's not just having the plan there, but it's taking it, using it, and designing it from the beginning with that in mind. And a second example, if I may, that we've seen is in Vietnam with our implementing partner PATH. We were very proud to support a program for the elimination of mother-to-child transmission in one local area. And based on the emerging success of those projects, the emerging results and lessons learned, the colleagues at PATH, together with the leadership and governance of the provincial government, were then able to share the lessons learned and the benefits of this program. And that's something that's now been scaled up at the provincial level. It's fully funded and it's now available across the province. So we can make a lot of strides by listening to the lessons learned from those that are working on the ground and from people with lived experience. It has huge power.
Thank you so much, Jade. I think this is a very pertinent point. So I am not WhatsApping my friends. I'm actually checking the Q&A on our live stream. Yeah, a disclaimer. So we have one great question from the audience online. We spoke about national plans from very public health elimination perspective, but we've all kind of alluded to this, right? There is, I think public health is still very human in nature. We spoke about the fact that there is stigma and discrimination due to the lack of health awareness or the awareness of the condition at the Gen Pop level. And it's even more difficult when you have the more marginalized or isolated key populations that we're addressing. So the question, in short, is hepatitis B, but I don't think it limits to hepatitis B. I think it's just broad hepatitis conditions in general, has immense social implications in many countries in Asia. So the social element of the national plan is as important as the clinical implementation of hepatitis responses. So this include extending the national plan implementation into various settings like workplace, maybe even healthcare, and at the broader general level. So can activity occur within countries and across the region to reduce the harm resulting from testing? Because we can increase testing, but what do they do with that, right? That social element needs to come in. So maybe can I turn back to Dr. Chatri and Dr. Tran to give your perspectives from the national plan perspective, then I'll turn back to Roberta and Jane. Dr. Chatri, please.
Your question, perspective for hepatitis B in the...
It's just general hepatitis to address stigma and discrimination.
Okay.
Yeah.
In Thailand, I think the stigma and discrimination for hepatitis B and C is low when compared with HIV. But we don't have a formal survey to do this, but it's begin in this year to survey about the stigma of hepatitis B and C. In the past, Thailand have a program with hepatitis B. If you have a chronic hepatitis B, you cannot work for some career that is not related to infection. So that you have so that you want to be a officer or something not related to infection, you cannot. But now we have a law to ensure that people people or organization that not discrimination to race or infection such as HIV, hepatitis B, including hepatitis B and C. We have the law, but I think Thailand is a low discrimination. But we will survey again in this year.
Thank you so much, Dr. Chatri. Definitely the definition of leading by change, right? Or driving leading by example would be more accurate. Dr. Chan, please.
In Vietnam, the stigma and discrimination is also low, even very low, because we have a successful program for SIV, and even the SIV patient now they still alive, they still working, and a lot of story was public in the other channel. So in Vietnam, I think so. For myself, I can say that Vietnam do very well for reduce stigma and discrimination for HIV and of course for hepatitis. And I think mainly of the last question to know about how to driving the elimination for hepatitis. So if I choose one, so I will focus on screening by primary level, primary healthcare level. So as the open remark from Dr. The permanent the secretary, he says the viral hepatitis is a silent killer. The problem is no one know about their situation. In that's the popular situation in local level. So I think so. For my perspectives, I will focus on the screening in local level.
Thank you so much, Dr. Tran. I think this makes a lot of sense because the more you normalize that this is a natural way of how very much like how we go for a regular health screening, right? Then the more you will reduce stigma, the more you fear, the less you know, the more you fear, basically, right? So Jade, do you have any response to that question?
I'm probably not as best placed as my two colleagues here, but I would say I think it raises an interesting point that when we're developing national action plans, there's not one for diagnosis, there's one for screening, there's one for diagnosis, there's one for treatment, and there's one for linkage to care. We want to look at this holistically, and that's really sort of the art and the challenge of designing these plans, is bringing together that continuum all together from the perspective of it's the same person that is going to be moving through the system, that it has to be patient-centric and it has to be person-centered in order to connect those dots.
Thank you. Roberta, do you have any comments to add?
Just maybe 2 points to add. So number one, from a patient perspective, we will be fortunate enough to have people with lived experience later sharing with us. So I think they will be the best people to share. But I think from my perspective, we can only address stigma and misinformation with appropriate knowledge. So that's one. The second thing is also that across the region, there are still many examples of countries where hepatitis is stigmatized also in the professional setting, right? And also from a policy implementation. So I understand we have good examples here from Thailand and Vietnam, and there are many other countries who are doing well, but there are still a number of countries where we need to make sure that if we are diagnosed with hepatitis, we can still work. And this is not the case yet. So there are these two angles, I think. One is awareness and one is fair policy.
Absolutely. So I'm just mindful of time. So I think that is a response to the person that posted the question, but I will mention that comment, but I think I will park it for panel 3, as Roberta rightly pointed out. I think he is Vietnamese. So he mentioned that many Vietnamese talk about losing job opportunities as a result of their infection in the context of seeking an immigration visa for work. But this is the panel on national plans. So I would like to commit that we will caveat this and I will throw the ball into Dr. Ho's court where she will moderate and take note of this discussion, because I think that's where it will be the right time for us to expound on this. But jokes aside, I have one last question. We spoke a lot about monitoring and surveillance. We spoke about continuous feedback loop, because you are right. The people that we want to impact and benefit are the ones that should have input on this. And I think from what Dr. Chatri and Dr. Tran has mentioned, it seems like you're very cognizant of this fact, right? You need to see what's scalable, what are the pilots that are working, how can we scale this? That's why key terms like decentralization, monitoring and surveillance, making sure you have accessibility to screening are now keywords that I've heard, I think at least mentioned 10 times across the entire panel discussion. So as a closing question to all my panelists, what do you think is the one thing we need to do to ensure that this continuous feedback loop allows you to make sure that plan is able to be agile, so that we can, we just need to make minor refinements so that your national plan can really have the aspirations or the objectives that you want to meet when you put that plan together. So maybe I'll pass over to Dr. Chatri to start first.
To ensure the sustainable of implementation of national plan, I think several mechanisms can be established. The first one is a strong policy framework. Let's develop a robust policy framework that supports funding, resource allocation for hepatitis. And the second is capacity building. Invest in training healthcare provider at all levels that ensure they have a necessary skill for treatment and prevention for hepatitis. The third is data monitoring and evaluation to adjust the action plan. And I think is other important thing is feedback from other stakeholders. I think we need to regular meeting and some survey for information for you the feedback from stakeholders, include the patient, to adjust the plan.
Thank you so much, Dr. Chatri. Dr. Tran, how about that one thing that you think we need to focus on to make sure that the national plan remains relevant?
The resources.
From whom?
Yeah, that's from whom. Just small comment. Small comment before, so I answer the question. So in the morning, so I saw some analysis from the hepatitis fund from Dr. Win Brown, but officially I heard that information, but it's officially, so Ministry of Health, we do not receive any official data. So I know that's a lot of the organization department partner. They have many projects in Vietnam, but they go to they go through the local NGO, local and other international NGO, and they conduct some activity in small scale, and even so we are Ministry of Health, but we not receive all that information, all data from that project. So that's an example for I mentioned on the resources, how to mobilize the resources, how to coordinate the resources. So it's the way we need to focus. The resources also come from central level. We will work with the Ministry of Finance to make sure enough to locate any funding to cancel and expanding the coverage of the national social insurance. Currently, so for Hep B treatment now, so 80% coverage, and Hep C 50%, and now so we continue to working with the health insurance to expand the coverage, and also the resources from local, because in Vietnam, so we have a law of locality, so it's an empower for local level. They active to have to conduct some activity for in local level. So we can. I think that we can mobilize the resource from local level, and of course international and as a department partner resources. And that's again, so I want to mention, so any information, any project, and any from activity from the NGO and international partner, so we should inform the Ministry of Health. We will we will coordinate all information. It will support for our national action plan.
Thank you so much, Dr. Chen. I think that's a great tip for a lot of people here as well as online. I think the power of information from all angles is always very, all power of collaboration is very effective, right? So, Jane?
Definitely well noted. And if I can, I'm going to say that there are two things for us to think about. One is to think about national planning as a process. It's not a one-off moment, but it's a continuous ongoing dialogue between the ministries, international NGOs, funders, people with lived experience. It's something that we should all continuously be thinking about doing and how we can collaborate in. And the second is to echo Dr. Tran, is resources. We know from the latest data from the WHO that 70% of countries have a national action plan, but where those barriers are in implementation, that it's spotty at best, and financing is one of the key reasons that plans do not move to implementation. So just to echo some of the conversations we've been having today, is to think about resourcing and financing from the very beginning in the design of the plan, considering things like innovative financing mechanisms, how to integrate viral hepatitis into existing programs like UHC or maternal and child health to reduce costs, and to find where there may be efficiency gains.
So Jade has given the prelude to the panel after lunch, but we'll come back to that way better than I did. But maybe last but not least, I'll pass over to Roberta.
Maybe just one more point, because I will not repeat what my colleagues already mentioned, which are for sure the key points. One thing could be also explore opportunities to integrate hepatitis elimination efforts within other health programs in order to save costs and maximize operational efficiencies, and also to shift towards a more holistic approach to patient care, right? Rather than siloed approaches by disease. So that could be also a reflection. And I'm curious to know in the next panels, I'm sure that these will be also explored. Yeah, thanks, Candice.
Thank you. So we've started to move into the pragmatic element of the implementation of the national plan, and this was by design, and we knew that was going to inch towards panel discussion too. So we will come back and we will have that continued discussion into panel discussion too. But thank you so much, everyone, for being such attentive audience, and thank you to the amazing panelists for kicking us off with such an engaging discussion. So thank you so much, Dr. Chatri, Dr. Tran, Jade, and Roberta. Can we please give our panel a round of applause, please? Thank you so much. I'd like to invite you back to your seats. So I'm going to change hat again. I'm back to being the MC. So here we are. So I'd like to maybe say that we're going to do a lunch break. I'm just quickly checking on time. We are at 12:28, just on time for lunch. So for everyone who is here and online, we will come back at 1:30 after our lunch break. So for those who are joining us online, see you back here in an hour. So for our guests, we will have the team and the hotel staff will usher you to level 3 for lunch. So thank you so much, and we will see you back here in an hour. Thank you, everyone.